thank you, Sally, for the nice introduction, and to the organizers of this meeting for inviting me to speak to all of you, firstly about bone health management in boys with DMD, um, discussing the 2018 standards of care, but also bringing some ideas of how we move beyond. In this next two talks, what I will do is highlight some of the updated consensus recommendations in the 2018 standards of care, highlight some issues where there might be issues about implementation in your country, share with you how we've done it in Glasgow and in UK. It may work for your setting, it might not, but that's okay. Bring up some issues about implementing some of these care issues in adults with DMD, which can be extremely challenging because the 2018 standards of care perhaps is much more pediatric centric. And along the way, get you to think about research into care and how we can also involve patients in the next iteration of the Duchenne standards of care. And I hope this will not just give you information, but give you some food for thought. So bone and muscles are very closely related in a growing child. And we know that as muscles develop during childhood, bone develops, and that is largely in response to physical activity, in particular, impact-based physical activity, and particularly much more intensive-based physical activity. We also know as children grow during childhood and puberty, bones not only become longer and therefore the child becomes taller, but much more bone is also formed. And we also know that nutrition, like calcium and vitamin D, is very important for the minerals that make up the bones. And therefore, in a boy with DMD, given that the primary issue is with the muscular dystrophy, and we know that most boys with DMD, even in the ambulatory phase, are doing perhaps less and certainly less intensive activity compared to a healthy boy, we can see that that itself can impact on bone development. And indeed, prior to the era when steroids was used for treatment of DMD, fractures were already seen. But with the use of steroids like prednisolone and deflazacort, we know that whilst they are very useful for a whole range of health issues at DMD, it does have a negative impact on bone itself and certainly impact on growth and also puberty. Given that growth and puberty are important for bone development, we can see how steroids can impact on bone indirectly via hampering or interfering with growth and puberty. We know that some boys with DMD perhaps may spend less time outdoors and perhaps more pertinent in some of the older adolescents or men, and therefore a lack of exposure to sunshine, and therefore more of these boys and men may be vitamin D deficient, which necessitate taking a supplementation. Whilst in a Western-based diet, calcium intake from dairy product is usually sufficient. In some patients, calcium intake may also be insufficient. So we can see how there are numerous factors which would normally impact on bone development positively during childhood, but in a young person with DMD, as a result of the muscle condition and use of steroid, bone development is affected and bones are certainly much more fragile. So what are the kind of abnormalities that we see in the bones of a boy with DMD? And these are some MRI images of a boy with DMD and also a healthy control. And this is a slice through the thigh, looking at the big thighs and also the thigh bones. And whilst most of you will know that muscle imaging is a useful tool, at least in research and in clinical trials of DMD, to assess the impact of the disease and the disease progression itself. In Glasgow, we have been using MRI to try to understand the inner structure of the bones, and I'll take you through them. So if you look at these figures, figure 1, you can see that on the right is a MRI cross-section of a boy with DMD. In dark gray, a muscle area, and you can see that in the healthy boy, there is a lot more muscle. But in a boy with DMD, as most of you will probably know, it's actually infiltrated with a lot of fat. So let's look at the bones themselves. This is a section of what we call the femur bone. And you can see that if you compare these two images, the boy with DMD not only have got thinner hard bone or the cortical bone, but it's also much smaller. And this smaller and thinner bone is the reason why boys with DMD fracture their long bones, like their femur, which is extremely common. But using MRI, we can also look at a part of the bone called the trabecular bone, which is what we call the spongy bone. And in the femur, when we use a clever algorithm to study these images, and also we're able to quantify them, which I will not show you today, you can clearly see that compared with a healthy 11-year-old boy and an 11-year-old boy with Duchenne on steroids, and bone is on these images are the white images, whereas black is where there's no bone. You can clearly see there's less bone and there's poorer quality in a boy with DMD. These trabecular bones are very rich in the backbone or in the spine, and we believe that it is this abnormal trabecular bone which leads to spine compression fracture. And we of course know that pathological fractures or fragility fractures are very common, and at least about 50% of boys with DMD will have one symptomatic fracture. And this is from a study that we conducted a few years ago using all boys managed in Scotland from X-rays. A long bone fracture can cause pain, but in various studies, about 50% of boys with DMD following first long bone fracture can lose ambulation early. And therefore, if a boy with DMD has a long bone fracture and is still ambulant, consideration of an operative way of managing those fractures rather than putting the boy in a cast for a prolonged period of time is useful with intensive physio to prolong ambulation. We also know that if a boy is in a cast for 6 to 8 weeks and not mobilizing, that itself can lead to bone loss. So it's something that is useful to discuss with the treating orthopedic people, clinicians. A very rare side effect of long bone fractures in DMD and some other condition is this condition called fat embolism syndrome, which can occur after a long bone fracture or falls in DMD. And there are a handful of case reports which have been described, and I'll come back to that in the next slide. But compression fracture of the back or vertebral fractures are extremely common, and is probably grossly underestimated if diagnosed purely just on back pain. Spine compression fractures can cause chronic low-grade back pain, and it can also cause other health issues. What's not described in DMD, we know that postmenopausal women, for instance, who have fragile bones and sustain vertebral fractures, if the vertebral fractures are multiple, over time, these might lead to a deformity of the back called kyphosis, a bent bit on the back, bit of the back, and may also lead to some impact on the amount of volume of the chest and breathing issues. And this has not been described in a boy with DMD, but obviously these are concerns, and therefore paying attention to all these fractures are important. Just want to come back to fat embolism syndrome again. And fat embolism syndrome, like I say, is rare, but it's worthwhile noting in following a fracture in a boy with DMD. It's thought to be due to fat globules that sits in the bone marrow in the middle of the bone, and as a result of a fracture of injury, travels to the bloodstream and goes to various different organs, including the lungs, and causes almost fat clotting the lungs and lead to breathing difficulties or low oxygen level. It can also travel to the brain and cause neurological abnormalities like being very confused, and certainly can also cause what we call petechial rashes, or little tiny purple type rashes, similar to what you see in children or adults who develop sepsis or meningitis. So if you see that, that's something to raise this awareness to the treating clinician, because it is an extremely rare complication. Using an MRI method of looking at bone, we were also able to look at the amount of fat in these bone marrow. And what we can see that, and we prove for the first time this theory that it is due to showering, fat embolism syndrome happens because of these increased fat in the bone marrow. And certainly we can see that in boys with DMD, the amount of fat in the bone marrow is much higher compared to a group of age-matched controls. So let's come back to vertebral fractures or spine compression fractures. And I just wanted to show you some images and x-rays and show you what's normal and what are mild and severe vertebral fractures if you've not seen them. So these images are taken from the lateral position or from the side on. And in this image of the normal spine, where there are no fractures, you can see that all the shape of the vertebra are rectangle in shape. So there's no fracture in this boy on the left. And this boy on the right, where you can see that almost practically every single backbone of vertebra is not rectangle in shape. You can quite easily see that. Even a non-expert can see that once you're told. And they're all pretty much almost all of them are moderately to severely fractured or compressed. On the other hand, in this image in the middle, there are a handful of vertebra where there's probably mild compression fractures. And what we do believe is that these x-rays should be done routinely, because when present, first they will progress and become and turn from mild to moderate to severe. And also more vertebra will be affected even if you just identify one with time. And therefore, there are some things that we've learned over time about vertebral fractures or spine compression fractures, in that if we depend purely on presentation with back pain, about 10 to 20% of boys with DMD treated with steroids can have spine compression fractures. But we do know that spine compression fractures can present without pain or with just minimal pain. But when spine compression fractures are identified on these spine images, this shows that the bones are very weak, and therefore, in the updated 2018 standards of care, x-rays to screen for these fractures are now recommended. This next slide just talks to you about the two methods we can actually use to screen for spine compression fractures. Most are done with x-rays, but in certain centers, certain kind of DEXA or bone density scan, particularly certain types of model and the newer generation ones, can not only measure bone density, but also produce an image which is of good enough quality, similar to an x-ray, to diagnose compression fracture. And I thought it's useful to highlight this because there are certain patients who I've met over time in the UK who are managed in certain centers who say that they have not actually received an x-ray to rule out spine compression fractures, but I do know that in those centers, it is done using those special DEXA scans. So it's worthwhile just knowing. And this next slide really tells you the different position that a pediatric boy with Duchenne may actually undergo for a DEXA or bone density scan. Generally, we measure bone density in the whole body, or what we call the total body scan, and you just lie flat. We also look at the bone density in the spine, where you need to be in this sort of a position. But if your son or you've had a DEXA scan which allows evaluation of vertebral fracture, generally you need to be lying on your side. So if you have not had that, it does mean that actually the DEXA scan was purely just to measure bone density. So what does the 2018 updated consensus tell about bone monitoring? It recommends that boys on steroids should have an imaging of the back to screen for compression fracture every 1 to 2 years. And it's based on expert opinion. 1, 2 years is quite different. And my feel is that doing it every 2 years is probably not sufficient if you're trying to screen and identify them at the earliest possibility. I also feel that actually there might be some differences between the interval of how frequent you do these images based on the type of steroid regimen you take, because there are now some emerging data showing that these spine compression fractures might be different depending on the steroid regimen you take, but more research is needed in this area. It also says that all boys should have a DEXA scan to measure bone density once a year. But pediatric DEXA scan particularly is something that is not available in every single center and certainly not in every country. And the expertise to be able to interpret what this DEXA scan means is also not available. And therefore, if there is limited access to DEXA, or you do have a choice to pick where you might have to choose, for instance, in some countries where health insurance preclude the use, the availability of the 2 scans, an X-ray or a DEXA that looks at the vertebral fracture should be prioritized rather than a DEXA scan to measure bone density. There are some issues with bone monitoring pathway for the adult with DMD. More adults will have degrees of moderate or severe scoliosis, and trying to evaluate vertebral fractures on these back images in a man with severe scoliosis can be challenging. The positions required to put a young man for a DEXA scan in an adult population is also difficult. But more importantly, I think what is important is that in an adult with DMD, if you can't routinely do spine imaging, if there is back pain which is severe, new on onset, and different from what is expected, and if the X-ray is not of sufficient quality, other forms of imaging should be considered by a doctor, and this could include things like MRI or CT scan. The care consensus, as the video mentioned, also talks about the need for vitamin D supplementation, and also blood testing once a year to ensure that your vitamin D levels are in the sufficient ranges. It also recommends referral to an endocrinologist or a bone specialist to discuss the use of bone protective medicines and predominantly bisphosphonate infusions if a boy with DMD has sustained a long bone fracture with either no injury or very minimal injury, or if there is compression fracture with or without back pain. Let's talk about what bisphosphonates are, and some of you may have some idea of bisphosphonate because it is a medicine which helps to improve bone by reducing the amount of bone that is broken down. It is used very routinely in postmenopausal osteoporosis, and it does make sense because the problem with postmenopausal osteoporosis is an underlying bone problem due to an increase in the amount of bone that's broken down. In steroid-treated patients like DMD, steroids dampen all the metabolic activity of the bones, and in fact, bone formation is actually reduced. And really what we need for DMD is an agent or a medicine which increases the amount of bone that is formed. And we don't really have that medicine in pediatrics as yet, but there are some which may be emerging. Bisphosphonate can be given as a tablet, but it does cause indigestion and is not really recommended routinely in accordance with standards of care. But in this last year or so, with difficulties in accessing healthcare, difficulty in cannulation in some boys with DMD and some of the older men, I have used bisphosphonate tablets in select cases. It is also thought to not be as effective in growing children. Bisphosphonate infusions that are generally used in DMD are permethrinate or zoledronate, and this next slide will talk about the differences between these two medicines. Particularly with the first dose, you have a flu-like reaction, which can be mild and in some a little bit more severe. It is, I guess, reasonably similar to a COVID vaccination reaction, I guess. Permethrinate is a bisphosphonate that is given every 4 monthly, and it's usually each time needs to be given over 3 days. The infusion time is longer, usually several hours, whereas zoledronate is used a lot more in most centers these days, but they work just as well. It is much more potent, so a stronger medicine, and therefore is given once a day every 6 months during childhood for the first few years. And the infusion time is generally under an hour. But there is a feel that the side effects, particularly with first dose, can be a bit more common with zoledronate, particularly nausea, fever, and aches, and the need for more steroids or stress dose steroids on first dose infusion of bisphosphonate should be considered, and I'll talk about that in the next talk. Once we identify that a boy with DMD has fractures and bisphosphonate is started, it is given frequently till completion of growth, and then thereafter, the standards of care and the evidence is very limited on what we do, but generally, there is thought that perhaps some kind of bone protective therapy is still needed, particularly if the young man, as he transitions to adult care, continues on steroids. But this is something that which we will learn in due time. So just going through again, who are boys with DMD who should get bisphosphonate? Clearly those who have painful vertebral fractures. But the updated standards of care suggest that if we perform this screening spine imaging and we identify fractures which are in the moderate or severe grade, even without back pain, this is a trigger for treatment with bisphosphonate. And you can see these pictures which shows the degree of the vertebral fractures. It also recommends consideration of bisphosphonate with long bone fractures with limited injury. What are some of the challenges in implementation? So there is variability in expertise in reading these vertebral fractures between centers, and that is well known. And we recently published a paper using using images from boys with DMD, where we found that in fact, 2 experienced readers were very, very concordant in their diagnosis and grading of vertebral fractures with no impact on care in accordance with standards of care. But when a less experienced reader read these images, they were not so concordant with the expert readers, and it did lead to differences in clinical management, and that is an issue. Another issue relates to the kind of spine image reporting that we get from our X-ray radiographers. This is not an issue just in pediatrics, and certainly in the UK, in adult care of postmenopausal women with osteoporosis, this is also an issue, where a lot of these X-ray reports are very ambiguous, where they do not use the clear word of fracture, where grading of fracture is not made. So rather, so it is equivalent to someone describing that they've seen a tiger, for instance. They've spent lots and lots of fancy words to describe a tiger, and different people might interpret that report differently. And this next slide really tells you some of this issue. And this is an audit that we've really just done using all the spine images in boys with DMD performed in 2019. And only 3% of these radiologists report commented on the visibility of the vertebra. Only 19% used the terminology fracture or no fracture clearly. and really only 5% graded the abnormality. So it is dependent on somebody like myself within CHESS to review these x-rays together. And what's more important, and actually an issue which I think we need to collectively think of a solution, is that I then anonymized this report, sent it to 2 neuromuscular clinicians and 2 endocrinologists, and there was only 38% in concordance in the clinical diagnosis based on those reports. And even less so when there were some abnormalities described in the report. So what are the implications? And the implications are clinical reports from different sites, firstly, are not sufficiently reliable if we want to do a multi-center study of vertebral fractures in DMD, and we've got to be clear about that. But it also may mean that this is an issue which might be an area of variability in clinical care delivered. And tagged onto this, the expertise of the people reading this report, these images may be variable, and some solutions which we are hoping to try to develop is some structured online education for clinicians reporting these outcomes and the development of some structured reporting outcomes. And I think this is important so that we can then pull data together and actually deliver care appropriately. What do bisphosphonates do? And at the point of the development of the standards of care, this was only based on one very small series of about 7 boys with vertebral fractures in DMD treated in Canada. It improves back pain if the boy presented with back pain as a result of vertebral fractures. It stabilizes existing vertebral fracture, and it seems to improve bone density, but we're not quite clear that it actually significantly reduces long bone fracture. The slide, however, shows you a graph from a recently accepted manuscript from the first and randomized controlled trial of zoledronic acid or zoledronate in 62 boys with DMD from several centers in Australia and New Zealand. And this is excellent. This is, again, a trial which took, I think, about 11 years to, from inception to publication. And it is, for once, results which supports the recommendations of the standards of care, but in a randomized controlled trial. So what this trial shows, in brief, shows the spine bone density, and you can see that at start, the control and those who were on zoledronate were very similar. And by 12 months and at 24 months, you can see that the spine bone density was significantly higher in those treated with zoledronate. The study also shows that the number of boys with severe or grade 3 vertebral fracture was much lower in those who were treated with zoledronate, although the number of events was small to make meaningful statistical analysis. Bisphosphonate is useful, but bisphosphonate probably doesn't improve the thickness of the bones, but maybe addressing puberty may. On average, healthy boys start puberty at approximately 11 years of age, and the majority of boys with DMD, especially those on daily steroids, will not start puberty even if we wait till 14 or 15 years of age. Male hormones or testosterone are very important for growth, for bones, muscles, and actually very important for self-esteem as well. And the updated 2018 standards of care recommends that puberty should be assessed from the age of 9 6-monthly. And with a lot of us feel that perhaps it's much more realistic to assess puberty in a boy from the age of 12, but perhaps start inquiring or discussing puberty from the age of 9. And that testosterone treatment can be used to induce or take a young adolescent through puberty from the age of 14, but can be considered from the age of 12. And I certainly think that we should be starting moving the goalpost so that treatment is started a bit earlier, because several recent studies show that one, it's safe and well accepted. There is small amount of improvement in growth. It seems to stabilize bone density. And a clinical trial from the Newcastle team that was published, I think, early this year, shows that there may be some improvement of testosterone treatment or muscle imaging in DMD, although not muscle function, but it was only a small study. So perhaps these treatment may also have a small amount of effect on muscle, but certainly what it shows is that it is safe, and it certainly doesn't cause any issues of concern as a whole. So how do we deliver endocrine care in Glasgow for boys with DMD? Monitoring and the stress dose education is done in the neuromuscular clinic, largely by the neuromuscular nurse specialist. We have a monthly joint pediatric neuromuscular endocrine clinic for boys with DMD, where the main people I actually want there is the neuromuscular physiotherapist, because it's important to discuss posture, fall prevention, and these are things which I've discussed. And since early last year, which we have developed, is a transition young adult neuromuscular endocrine clinic with an adult endocrine and bone specialist. And we will hopefully in the next year share more of our experience as we are seeing these boys together jointly up to the age of about 21 to 22. So how are we doing in Glasgow, auditing against the international standards of care? And again, in 2019, we found that 96% were prescribed a vitamin D supplementation. 76% had a blood test for vitamin D levels. 74% had a lateral spine X-ray for vertebral fracture assessment. And we were doing quite well in 2019 that all boys who were 12 years or older had an assessment of puberty. But auditing how we're implementing care at the level of several sites or in a country is important, and it allows benchmarking. But implementing recommended standards of care is an issue because a nice work from Imelda's group, I think the Netherlands group, of a qualitative interview of a group of clinicians delivering care to DMD, not just in bone, shows that sometimes when clinicians do not adhere to recommended care standards, even if it's international standards, it's because there was lack of expected outcome, there was lack of evidence, and some say maybe they're not as familiar with the recommended standards of care. And therefore, whilst the 2018 standards of care is excellent, there must be some issues of seeing how it fits into your country, fits into your healthcare system. And perhaps there need to be prioritizations of aspects to implement depending on the resource in your country and in your hospital. But one thing that I would like to urge out for this group is that I think as a group, we should not just start thinking into research, not just into cure, but into care of rare conditions, in particular DMD. And finally, that actually, given that so many aspects of this international standards of care or care of DMD, it's largely still expert opinion, perhaps one voice that's still actually missing from the 2018 standards of care, as far as I'm aware, is the patient's perspective. And perhaps at the next version of the standards of care, we need to think of how we actually involve the patient's voice, working together with clinicians into developing care for the people themselves. So finally, I just want to summarize a few points that fractures in osteoporosis are very common in DMD, and it's due to the muscle issue and also steroids. It's not just a steroid issue. So even if we have new steroid sparing agents, I think osteoporosis is still going to be an issue, but less so. We need to start identifying fractures, particularly vertebral fractures, at the earliest possibility. But there are some issues, as I have mentioned. But do not ignore puberty, because this is very important and also important for quality of life and self-esteem of the adolescent. But collectively, we also need to ensure that expertise of bone health or any other aspects of care that that's been discussed in the 4 days is not just limited to certain centers, and to ensure that care is consistent and that research into care is important. And perhaps we need to also see how we can involve patients at the development of standards of care. So thank you very much, and happy to take questions.